Assalamu alaikum. On behalf of Deanship of our college and Department of Pediatrics, we welcome Dr. Babar Hassan from Islamic Republic of Pakistan. Dr. Babar Hassan, he is visiting Iraq and Najaf city among a medical committee in response to invitation by the Najaf Center for the cardiac surgery and cardiologic interventions, and to do some of the complex and advanced surgeries in the pediatric cardiology especially. And we invest the valuable presence of his to give some of lectures for our students. Dr. Babar Hassan, he is an associate professor in Aga Khan University in Karachi, and he is a consultant in pediatric cardiology. He has a degree of American board in pediatric cardiology. It's a great honor to have him in our university, and we and you are so excited to listen to his lecture today about the congenital heart disease. We already did and invest his presence last Thursday when he talked about the congenital heart disease. We regard it as a part one, and today he will talk about the advances in modalities of the management and the artificial intelligence in the management of the congenital heart disease. Dr. Hassan, you can take it.
Perfect. It's an honor to be here. I graduated from the Aga Khan University in 1999, and then I went to the US and did my pediatric residency from Indiana, and then did my fellowship from Boston Children's in cardiology, cardiac intervention and imaging. And then in 2011, I came back to Pakistan. And then, when I was in the US for 10 years, not for a single day had I come back to Pakistan, because I was on a J1 visa. I didn't want to risk coming back. And it was right after 9/11, so you can imagine anybody with the name of Hassan, and everybody, all the dogs are there and everything. So I was scared of coming back, of traveling. And so in the US, every dinner or lunch that you go to where Pakistanis came, they all came in their BMWs and their Rolls Royce, and they all wanted to solve the problems of Pakistan. That we should do this, we should do this, everything is happening bad, we should do this. And so the day that I said I'm going to go back, everybody came to my house and said, "You're crazy, why are you going back? You should not go back. Because you have come out of Harvard, you should stay here, your career is going to be great. Why are you going back?" And I said, "Well, you were saying that we should go back. Why are you now saying I shouldn't go back?" So I think what I believe in, and it's something that one of the surgeons, Aldo Castaneda, who is a big name in congenital heart disease surgery from Guatemala, taught me once, that if you want to make a difference in your countries, you don't do medical safaris. You just don't go once a year, do a couple of cases, come back. You have to be there to make a difference. So people like Dr. Dafar, for example, or Dr. Vada, these people are here trying to make a difference. Okay. The second thing which I kind of realized over time is that the high-income countries, they at times do not understand our problems, what we face. What is congenital heart disease in our setup? What do me or Dr. Dafar see in our clinic? And how do we deal with it? And it is very different. So my topic today is to kind of give you that spectrum of what we see as difference in our part of the world. Same heart disease that you see in the US, how would they have a better outcome, and why do we struggle with our outcomes? But I'm not going to stand here and cry about it. I'll give you some solutions, some innovative solutions that I have adopted back home, and I strongly believe that artificial intelligence and digital transformation is a way of bringing democracy in healthcare. It's probably a way in which hopefully our countries can deliver the same kind of healthcare as it's done in the high income countries or the US or UK, whatever. So that's what this talk is all about. It's not going to sound as a very classic physiology talk that I gave last time. It's going to be more of a vision talk. I want you to, because you are the next generation of this country and of the Muslim Ummah. And I want you to think big, you know, and think how we can solve our problems. So why am I here in Iraq? Because there's another thing I believe very strongly in. It's that when people like Dr. Dafar, Dr. Wada, me, who understand our problems, when we collaborate, we solve it better. Adopting something from the high-income country and trying to bring it into our countries will not work. We have to work together. So I call it the South-South collaboration. It is the global South with global South that will collaborate to solve the problems. The global North typically cannot solve our problems. They will not understand how to deal with it. Okay? So this is principles of delivering congenital heart disease care in low-income countries. And as you go through this, I want you to think like this, that, you know, any kind of complicated care, it's not about putting the most expensive device in them or using the most expensive machine on them to diagnose them, but it is to provide that holistic care so that they eventually have a better outcome. I don't have any financial disclosures or financial association. I'm a poor doctor. I don't earn much, but the earning is all sawab that we all get. But I will state the truth and nothing but the truth. And I think that's important, because what you will see something as I go through the talk is some provocative things that you will say, why am I saying this? But that's the truth. That's the ground reality. Okay, so what are my objectives of the talk? I'm going to go through the challenges of congenital heart disease in low resource setting. And then I'm going to categorize those challenges and bring them into a solution. And then I'll use some specific use cases to highlight solutions. So people who are interested in the lingo of artificial intelligence will pick this lingo. Used case is like an example in which people have used artificial intelligence to improve delivery of care. So I'll show you some of those examples that we have used in our country. In my setup and stuff, and that's one of my research area, is to use artificial intelligence as a mode of delivering quality care. So why, when I was coming back to Pakistan, everybody said that Pakistan is a country of diarrhea, pneumonia, polio, right? Why are you even thinking of congenital heart disease? And they said that my talent will be wasted in Pakistan, you know. Just to give you an interesting statistics in Iraq, I think close to, at least that I know of, there's a list of at least 5,000 kids who are waiting to get surgery. At least minimum. This is what we know of. And probably Dr. Dafar knows even more. And I think so. So only 4 countries in this world, Pakistan, India, China, and Indonesia, contributes towards 50% of kids who are born with heart disease every year. So it is not the disease of the West. It is very much our disease. Because of our fertility, more kids are being born, okay? Consanguinity, intermarriages, okay? So there is a very high incidence. And so for example, in Pakistan, 60,000 kids are born with heart disease every year. And out of those, at least 30,000 need some kind of an intervention immediately in the first 1 month of life. And those who don't get intervention, they will survive as an adult with congenital heart disease, which is even more of a problem for the human capacity in the country. Okay, so how does heart disease present in the West? This is a picture from the internet, but this is a picture of one of my patients that I saw, okay? They both have the same disease, okay? So this is a child in America who is diagnosed in utero, fetal diagnosis of transposition. The baby is born big, huge, chunky, and they go to the best hospital. They get their treatment, and then they go to a family who has a good home, nice insurance, everything. They're not worried about money coming out, okay? And so their outcomes are naturally pretty good, you know. Same patient, transposition. This patient, guess how much the patient's age is. Just make a guess of this patient's age. How much? 6 months. Somebody said 6 months. Anybody else?
1 year.
1 year. This is a 2-year-old with transposition, okay, and severe malnutrition, and has an IV in, so he actually came to us with sepsis and renal failure, and has a late presenting transposition. Now treat this. So I asked my colleagues in the West, in the US, come and treat this for me now. And then treat this patient and send them back to this family in a remote village where they don't have care. Okay? So we can accept this situation and say, oh, you know what, we can't do much, let our kids die. Or we think innovatively. How can we innovate? How can we make sure that I don't get a child this late in the diagnosis? Is there a way in which I can diagnose them in utero without doing any fancy echoes? Is there a way? Okay, and I'll show you that way using artificial intelligence. Is there a way of then transferring that kid very quickly to my center? Okay, is there a way that when I treat them in my center and they go back to their village, which is at least 400, 500 kilometers away, as far as Basra from Najaf, okay, how do I remotely monitor them? Is there a way? And we have used WhatsApp, literally, that you'll have people sitting in the community, and they will do, we have technicians who do handheld echo, they put it on WhatsApp, put it on the group, and we have a way of following them. So they don't have to make that trip all the way 500 kilometers to come and get treatment. So all these solutions can come up. So as I said, 30% of 30,000 of those patients will die if they don't have intervention in the first 1 month of life. Those who survive become adults with congenital heart disease. This girl here is around 24-year-old, unrepaired tetralogy of Fallot. She is the sole earner of her family, okay? Because her father died very early. There are 4 sisters, and the other 3 sisters are young. So when she gets sick, all the other 3 sisters who are normal, they come out of school, okay? So this is a bread earner. All these 3 sisters had congenital heart disease. They all 3 had tetralogy of Fallot. Intermarriage, okay? Late presenting, all of this. This guy is a guy who's 32 years old. This is his brother, who is also a doctor. And this person had a very complex dextrocardia, CCTGA, congenitally and a VSD with pulmonary stenosis, very, very complex disease that he was unrepaired. His fingers was this big because of clubbing, okay? And so this guy actually, he was so complex that we couldn't take care of him at Aga Khan because I was just developing a center. I didn't have that much of expertise from a surgical group. So we actually arranged for him to go to India, to Rajesh Sharma. And Rajesh Sharma did his operation and fixed him and treated him. So what I'm saying is that South-South collaboration, because I wrote to my colleagues in the US and said, can I send him over to you? And they said, oh, we have never dealt with somebody this old. And then they gave me a total bill of like around $500,000. That, you know, if you submit $500,000, then we may look at him. So I wrote to Rajesh Sharma, I said, Rajesh, can you do this? And he said, yes, I'll do it, send it over. And it was $5,000, you know. So India, Pakistan, we may fight over each other, whatever. We may do everything, but when it comes to patient care, we are very collegial. We collaborate quite a bit. And so that whole South-South interaction and stuff. So what is also interesting, as I mentioned, this is a paper from India, from one of my mentors, K.K. Kumar, who's in Amrita. And so he wrote a paper showing that majority of the children presenting to us before operation had infections. So when I say that all of these problems are there, I'm not just making them up. This is all backed on data. So this comes from a very interesting registry which is known as the International Quality Improvement Collaborative, IQIC. And inshallah we'll get Najaf on it also. And IQIC gathers data from low middle income countries. So we looked at patients who had the more complicated the disease, the later they were presenting and the more infections they had. Okay, so which is very different than what you see in the West. Okay, so and these are some of the complications that you will see in patients who are presenting late. So and you probably have seen this in a lot of your patients in Iraq also, that they have severe clubbing. And this is a tetralogy of flow patient who presents late, has clubbing, has brain abscess, has infection, has poor lungs, are polycythemic, they bleed a lot during the operation. So all of these are, so yesterday, for example, we were doing a patient who was 2 years old, and as soon as we induced her on the table for anesthesia, she went into a TET spell, and her saturations were 25, because somebody who should have been operated at 6 months of age now is being lingering on because we don't have the expertise of doing that. And so now when you are doing the case, a simple case becomes very complicated. So 25 of saturation, we are rushing in, trying to open the chest, cannulate it and everything. But you can well imagine that there is a risk of putting a child into a brain injury. So late presentation is a problem that can cause a lot of issues and stuff. This is the ICU in Boston Children's where I trained. Okay, this is the Boston Children's team. This is our attending Ravi. Dr. Dave Brown, who is one of the cardiologists, some of our nurses, and literally this is, if I was to say, just half of the team. Usually the team is around 20 people. There's a social worker, there's a pharmacist, there is an interventionist, there is a cardiologist, there is a surgeon. So, there's a whole group of people who round on these patients. And then, look at how well equipped they are. They have really good equipment, monitors, and their cardiac ICU nurses are better than, when I went there, my first year of fellowship, I entered into a 30-bed cardiac ICU, and there was this 6'5" huge nurse who came to me and said, the only way you will survive tonight is that if you listen to me what I tell you to do, and you just sign the orders. And that's how I survived the night, because that's how good they are. They know exactly when the child is doing, they will extubate, they will intubate, they'll put chest tubes in, they are so good in the ICU. So all of this accounts for their outcomes or their improved outcomes, and these are the things that we say. This is the ICU in Kabul, where I also go and operate and do work in Kabul, and this is the ICU in Kabul, and this is one of the nurses in Kabul. And when we trained her for around 5 years, 6 years, and when she got trained, she went to Kuwait to get some more money. Okay, so that's also a problem. Our problem is our huge attrition. We lose nurses, we lose our high-powered people. And this is what people have shown. This is not something I'm making up. WHO came up with this whole ratio. So in countries like these are all these countries where you have a very high patient-to-doctor ratio. So the patients are thousands and the doctor is one. Okay, so how can you expect that one doctor to have now deliver high quality care and at the same time be compassionate? How can you will lose your compassion in 2 days, and you will start getting angry and all of those things. And then, it hurts us as physicians also, because when we go home, literally some days I'll go home and I'll say, why did I yell at that patient? I feel bad about it, because there's a parent who is worried. The parent is, has a child who is having problems. The child that we operated today, for 5 days they are sitting in the hospital. Every day when we go out, the father comes to us and say, when is Mariam getting operated? Then when we come back in, when is Mariam getting operated? So yesterday I got a little irritated. I said, we'll do it. And then I felt bad about it, that it's not his fault. He's just asking a question that when is my child going to get operated? But we are also humans. We want compassion. So this is a real problem also. So now, can you see the whole spectrum? Late presenting, late diagnosis, late presenting. Now they present to you with malnourished infection. Okay? And now you are doing the operation in a setup where you don't have that many high-skilled workers. You have nurses who you train and who run away to other countries. And you don't have the equipment. Okay? So all of those are your challenges. But we can easily sit and cry about it, or we can come up with solutions that we can teach each other. Because the solution that I come up with, and I call it the frugal implementation or frugal solution. The solution that I come up with will resonate better with you guys. It will not resonate with somebody in the US who has 20 echo machines, 4 cath labs, equipment that they can open as many times as they want, and nobody asks them. It will not resonate with them. They think that we are providing suboptimal care. But that is also something we'll prove. By being on these registries, we prove that by doing the way we are doing stuff, we are not providing suboptimal care. We are dealing with as complex of a patient with as good of an outcome. And that is when you turn the table and you tell them that, hey man, you learn from us. It's enough, yeah, you can teach us also, but you can learn from us how to do this. Why are you using 10 different echo machines? Do it on one, right? Because money is not limited, even unlimited. In the US also, money gets limited, so they can learn from us how to deliver care. So this is again the same thing that shows that there is a huge shortage of high healthcare workers in developing countries. And then this is something I really loved. This statement from an Indian doctor. So the lower salary ensures that only the poorest talent is available, because the more talented will go in for a private practice or they will go abroad. So people who are left behind, unfortunately, and it's not their fault, is also the poor talent. They are not your cream. The cream of the country is all sitting in the US or Germany or UK, But that does not mean that we cannot make ourselves better also, right? But that's also something that people who come back after getting trained, we have to get used to. You have to get used to that people who are standing now at the bedside may not be the best talent that you have in your country. But, there's always a way of attracting them and stuff. There is lack of specialized care. So Pakistan, for example, we have 2 centers in Sindh, one in 3 or 4 in Punjab. These are different provinces, and then one in KPK. Only 2 centers do neonatal surgeries. One center is in Sindh, which is my center, and then there is a center in Lahore, in Punjab, which does another center. So you can imagine the amount of patients that we have to deal with. And this is Balochistan, which shares border with Iran and Afghanistan. So patients from Afghanistan will come through this border, and they come to Sindh, to my center and stuff. So there's a huge volume that you have to deal with also. And so there are lack of specialized centers also, where you can actually deal with complex care and stuff. Just to give you an example, cath lab, for example, 37 programs were surveyed by the International Quality Improvement, 70% interventional cases, 50 to 60% programs had less than 2 interventional cardiologists, technicians, or nurses to do the cases. And then financial institutional commitments and equipment are the main barriers. So the barriers that people identified in our part of the world was that the institution was not committed towards congenital heart disease. And that's what I even see here, is that they all want to do adult because there's more money there. In pediatric, for example, 2 cases per day, we are distributing chocolates outside that, we did 2 cases today. Adult, they'll do 6 cases that day. But nobody understands that that 2 cases is equal to 12 cases of adult. This small baby getting access will take you 1 hour, right, Dr. Zafar? And then you get into the heart, and then you put a device in. It's not a joke. Coronary arteries, they just go in, 3 views, put the coronary stent in, you're done. But that commitment has to come from the country. That commitment has to come from the health ministry and even from the hospital, that congenital heart disease is our duty. It's not, we are not giving a privilege, or we are not doing what I call, kind of a charity work. No. This is our duty. We have to do it because these are our future generation. So congenital heart disease. So these are some of the constraints that we have. Money wise. There's a huge problem also. In Pakistan, for example, a device case will cost us around, $5,000. Now, the per capita income, if you look at people, is $1,500. So even a middle class person cannot afford that care. And as soon as you put them, and majority will actually have out of pocket payment. So I think even in Iraq, the same thing. Very few are government-funded insurances. Majority are people who are paying out of pocket. So when you pay out of pocket, what do? You cause financial risk to the family. You cause financial risk to the fact that, and look at how people get money. They borrow money from friends, they pledge gold, they private loans, selling gold, pledging property. This is a paper from India where people showed how do people get money to come to you to do a case or get a case done. And we don't even think about it sometimes, Oh yeah, I can't do it now, come back after 2 months. For somebody to come from Basra after 2 months, it's going to cost him at least, $200 to come, to rent a car, to come. So it's a lot of pain that one can inflict. And if that happens, that financial risk can happen into a family. So you can put them into a poverty trap and stuff. And so, and what is interesting in my country is that majority of the research fund comes into diseases like HIV, tuberculosis, malaria, polio. And there is no fund that comes into doing research for congenital heart disease, for rheumatic heart disease. Pakistan has the second largest rheumatic heart disease population in the world. The last funding that came to do research was in 2006. Okay, whilst just one case of polio, to decrease that one case of polio, they gave $10 million to decrease that one case of polio. So it's all this agenda. So until we don't ourselves invest into our own population, the foreign investor has their own agenda. Their agenda is COVID now. Everything is COVID. They want to give vaccine, COVID, right? What happens to the rest of the population, nobody cares. That care has to come from us, that we determine that this thing has to be done. So, and this is interesting that I sent a paper to the bulletin of the WHO. So World Health Organization, I sent a paper to them. I want to write about something, and this is what they wrote. Unfortunately, this initial assessment has resulted in your paper not being considered for publication. We think that your paper would be best suited to be a specialist or regional journal. Oh, you are the WHO. You're not going to let my paper publish in WHO, then where should I publish? So, and then they keep on saying that there's no data from LMIC. But there's no data because you don't let us publish. So there's this whole thing that one has to understand as we kind of go through and stuff. So anyhow, the challenges, so I break the challenges into these different buckets. So challenge bucket number 1 is that there's increased burden and complicated disease. And I showed you that, right? 60,000 kids are being born in Pakistan with heart disease every year. We don't have enough people. And the burden of the disease is very complicated. Infection, malnourishment, late presented. Bucket number 2 is a lack of expertise. We don't have skills, humans, equipment, resource, engagement of the workforce. Like people will just sit there. Like there's a patient with a blood pressure of 25, everybody's just sitting. Why are you sitting? Move. Right? But nobody wants, because again, you have to engage the workforce. How do they work with you? Bucket number 3 is quality as a privilege versus a right. So we think that giving quality care is a privilege. It is a right of every human. Would any one of us go to a hospital to get care if we know that they are providing suboptimal care or low quality care? Would we take our own child or loved one to that hospital? No. So if we don't take our own child to that hospital, why would we then say, oh, you know what, quality, I can't do quality, there's too much patients coming. No, you have to figure out how to give quality care with the same access that you are providing. Because quality care is the right of every human. It is not a privilege. Every human deserves that. Bucket number 4 is lack of healthcare organization commitment. So there is no commitment from the healthcare organization. How do they commit to delivering high quality care and stuff like that? And then bucket number 5 is lack of sustainable funding. So these are the buckets that I kind of put my challenges into. And then how do I solve them? I solve them bucket by bucket in that manner and stuff like that. So, again, in congenital heart disease, this is the care continuum. We recognize there is low awareness in the community, there's lack of echo availability, there is very little prenatal screening, little newborn screening, and then the referral is late And then referring them to a high quality center is also problematic because we don't have a referral system. And then once they get into a transport, the transport can be very, very problematic. And then treatment in a high quality, once they come to your center, if you don't have a well-trained nurse, if you don't have a well-trained physician, you can't deliver high quality care and stuff. So this care continuum, and so the solutions that you will see it according to the buckets that I have made and also according to this care continuum. Is there a way in which I can start picking my patients early? Is there a way in which I can start referring them early? Is there a way in which I get them through a safe transport system? And is there a way, once they get into my hospital and I treat them and they are in the ICU, how do I now manage them with a low-skilled nurse? Not a high-skilled nurse, because the high-skilled nurse is sitting in Kuwait. The low-skilled nurse is with you. So how do you deal with them? And so at each of these points, I have used some of the artificial intelligence solutions. And I'll show you some of them later on. So what is this? So again, so these are all the different modalities. So what we did was, so prevention, again, birth control, which is again going to be very difficult because it's education, mass level education, and people have shown that birth control strategies don't work that much. It's very, very difficult to do that. Early diagnosis, how can we improve that? Antenatal diagnosis, postnatal community level, and increase echo diagnostic ability. So using educational activities, certification courses, AI and technology, and then using some artificial intelligence on pulse oximeter, fetal Doppler, and I'll show you some of this. Don't worry, I'll show you some of this. And then effectively, timely and safe referral and transport. How do we use an ambulance service that can transport these patients safely? And that solution also, as we go through the talk, I'll show you. And then once we hit a cardiac center, how do we develop a center of excellence? And the center of excellence is developed only by introducing quality improvement in that center. So quality at the core, skill development using medical safaris or mentorship, focus of things that have the highest yield, nursing empowerment, retention, infection control, quality framework. So if you were developing a congenital heart disease program in your setup, focus on these 4 low-hanging fruits. Focus on nurse empowerment, make your nurse empowered. Focus on infection control. Focus on how do you improve quality framework in your hospital and stuff. And then human resource and task shifting. And then how do you manage irreversible diseases and its consequences like Eisenmenger's and cyanosis. And then doing research, innovation, and data generation. And then also going and advocating at the patient, at the family, at the government level. And these solutions are something that I'll show you. How did we do that? We engaged families, we engaged parents. One of the parents actually has made a whole society now. And he is the person who goes and advocates with the government. Because the government is very scared of the population. They can shun us off, physicians, because we are their employees. But they cannot shun off or they cannot tell the patient to go because the media can get involved. So you use all of those tactics to get funding, to get advocacy around congenital heart disease. Okay, so how did I started thinking of these solutions? So when I looked at the remotest village and I saw this person who was going on a camel cart and I saw a smartphone in his hand. And I said, this is interesting. So though he's going on a camel cart, he has a smartphone. He has access to internet. He has access to YouTube. He has access to WhatsApp, all of those. And that, in fact, this is a very interesting report from the World Bank report that showed that the mobile phone use and 3G and 4G and 5G network is far more rampant in low middle income countries. In our part of the world, there is more use of technology when it comes to phone and 3G and 4G. So if you know this, now you can think of solutions using that technology and those wearable devices and stuff. So this is our first project that we did. So this is a project that we did in a remote village, and I'll show you that village, and if the movie plays, I'll show you that movie in which we did this. This was funded by the Bill and Melinda Gates Foundation. It was initially a $300,000 fund, and then when we proved that we can make a model, we can make an algorithm, they gave us recently around $3 million to scale it, to make it big. And we have been working on some of the solutions into that. So what was this project? This project was that is there a way in which because every baby, because there's so much of focus on maternal and child health, that people have developed quite a bit of community level strength in looking at ultrasound of the baby, like head circumference, abdominal circumference, and some heart Dopplers, not the heart image, but just the Dopplers of the heart. So can we use the Dopplers of the heart to predict which fetus is at risk of having something bad when they are born? And we predicted 2 months before. So 2 months before the baby is born, you can predict that this baby has a chance of having a bad outcome after birth, which bad outcome can mean congenital heart disease, can mean that they are having, they will die because of asphyxia, because of infection. Something bad will happen to this child, okay? And if you can predict it 2 months before, you can put your lady health worker or your community health worker at that house, that they can keep on going and identifying that child very quickly. So, okay, so this is the village that we did this. It's a fishery village. And if this video plays, this is where we did it. You can see. So we did the artificial intelligence work in this setup. So it will replicate to any setup of this kind of a type. You know, so these are all the patients sitting there and stuff. So again, what was the primary outcome of this study? Was to identify patients or fetuses who will have a stillbirth or a neonatal mortality after birth. And then what were the secondary outcomes, which was interesting? Can we identify babies who will have prematurity, low birth weight, birth asphyxia, or early neonatal sepsis? Can we identify even those patients and stuff? Okay? So we had 866 scans. These are the different gestations that we did it on. And we had 25 stillbirths, early neonatal mortality was 19, and growth restricted babies were 117. So these are the different Dopplers that we kind of used, and so they were the LV outer tract Doppler, the mitral valve Doppler, the tricuspid valve Doppler. We used all of these Dopplers. Yes, we needed a high-skilled worker to get this Doppler because we were developing our algorithm. So in AI, you need a good data first to develop your algorithm, but our next step now is to make it so that we can only do it on 2 Dopplers, just the mitral valve and the LV outer tract. And we have now trained our lady health worker in the community to get those 2 Dopplers very easily. They can get a 4-chamber, they can get an LV outer tract view, and they can get this Doppler. And based on that Doppler, we can make some of these predictions. So, so this is a complex, and I'm not going to go into this. I just put it up there so I can impress you guys a little bit. So this is what we call a multi-kernel learning technique, in which we put the data onto a space, a digital space, and then we start identifying clusters. How does the patient cluster? And then based on that, we can predict whether the patient has, and we had a decent prediction of how of patients who were high risk of having neonatal mortality or whatever. This is the interesting part. So once we made our algorithm, this was made in Pakistan, in Karachi. We picked a Doppler of a baby that was diagnosed to have, of a fetus diagnosed to have tetralogy of Fallot in Barcelona, in Spain. We picked those Dopplers and we put it in our algorithm. The algorithm did not know that this child has tetralogy, this fetus has tetralogy of Fallot. And the algorithm was able to identify that fetus as a high-risk fetus, that there is something going on in the Doppler pattern of this baby, that this is a high-risk baby. So this fetus actually had tetralogy of Fallot. So you can use this even to identify some of the high-risk congenital heart. So if you have that early diagnosis, like in utero 2 months before, that you know that this baby actually has some kind of a problem, and at birth, now if we put something else at birth to facilitate even further the diagnosis of congenital heart disease, you can transport them early. You can diagnose them at day 1 of life. In the remotest part in the village, you can do that based on some of this. Okay, so this is my second project that I'm doing now. So this is a pulse oximeter project. This was funded by the Islamic Development Bank. And what we do is what is interesting. And I don't know whether you as medical students have looked at this, but the pulse oximeter has very different waveform for every disease.
We always look at the number, saturation 95%, 90%. We don't look at the waveform. The waveform is very different. So this is a waveform of a baby who was septic. This is the waveform of a baby who has congenital heart disease. Now just by looking at it, you can tell the difference, that there is some difference. So we use artificial intelligence to look at these waveforms. So that the artificial intelligence, so we look at this, we use the device, and we pulled out all these waveforms around 1 minute. This is multiple sets of data that we get in. And then we create these different clusters. Can you see this? So we create these different clusters using our MKL technique. And we are able to then identify patients who had, for example, who had congenital heart disease versus sepsis. So using pulse oximeter and the waveform and artificial intelligence, we can now tell whether this baby has neonatal sepsis or congenital heart disease. And it's a pulse ox, so you don't need anybody fancy. You just tell, even the mother can put the pulse ox. And the pulse ox can then Bluetooth to the phone, and the phone using 4G goes onto the network. The network runs this analysis or this algorithm literally over 5 minutes. It learns the algorithm over 5 minutes, and it sends a message to the phone saying this baby has a congenital heart disease, send them over. Send them to Aga Khan or whichever hospital is nearby. So now at 1 hour of life or 2 hours of life, you will have the diagnosis made. At least you will have the diagnosis in the sense that you have identified a child who otherwise would have been identified at 6 months of age. You know, so this is something that we have come up with. So the other thing we are doing is we are using the butterfly device. This is have you guys seen the butterfly device? So it links to your phone. So I always tell my students now, the stethoscope is going to be obsolete. Nobody's going to be using stethoscope. Everybody's going to have a butterfly in their pocket. They'll come, they take it out, do the echo quickly, and they'll say, oh, you know, this is what it is. So if we keep on, so even as medical students, why did I choose this topic today to talk to you guys? I could have come and start talking about, oh, this is S1, this is S2, this is the ejection systolic murmur, this is diastolic murmur. That's important. I'm not saying don't learn that. But in 5 years, that's going to be gone. Nobody's going to be saying this. What I will be asking in 5 years from you is, do you know how to use a handheld echo device? Because if you don't know how to use a handheld echo device, you are not equivalent to any other student in the world. So that's how we have to think. We have to think innovatively. We can't think like this, like what the medicine I learned 10 years ago is not going to be applicable to you 10 years from now. It's going to be very different. It's going to be very digital. It's going to be very different and new technologies. There are medical schools now in the US that are teaching students how to code, digital coding, so that you guys are comfortable in doing machine learning, coding, artificial intelligence. Because I work a lot with my engineer, and I've learned a lot of this lingo, but I cannot challenge my engineer until I don't know what they're talking about. So it's something I have to learn. I have to learn mathematics. I have to learn MKL. What is MKL? What is multi-kernel learning? What is XGBoost modeling? And because that's important for me to understand. So we have taught some of our sonographers in the community of how to use these handheld devices. And so this is one of our sonographers using a handheld device in the community, for example. This is our community worker who is teaching the community. This is me with my coffee, black coffee, so every morning. And so I'll go in the community and do some clinics and screen and whatever. But the main purpose of doing this clinical work is to teach all of these lady health and community health workers how to use these devices and stuff. And so you can see this. And then we are working on, this device, the butterfly device is still in an experimental model. On the phone will have a green box. So the technician will, or whoever is given that probe, will be told to just keep your hand in the green box. So they don't even know how to scan. They will just put it on the chest. They will scan as the green box will make them scan, and then the machine identifies the image, picks it up automatically. The echo machine identifies the handheld echo machine. It picks it up and then it puts it onto a network. On the network, we have devised an algorithm in which it will look at the heart, segment it, auto-segment it, and then say that there is chamber dilation, there is low EF, there is VSD. So some of these algorithms we are working on, these are known as convolutional neural networks. So we create these neural networks, and these are very fast. They can literally run these diagnostics over few minutes and tell the person in front that there is something on the heart that is going on. So I also use a digital stethoscope. So digital stethoscope augments the sound of the heart. So in patients with rheumatic heart disease, the time to pick them is for secondary prophylaxis. And secondary prophylaxis is given when they have indolent carditis or silent carditis. You can't hear it with the stethoscope. And you can't do echoes on everybody in the community. So we came up with the solution of using a digital stethoscope, and the digital stethoscope has this very loud phonocardiographic sound, okay, that shows on your phone, on your device, okay. And so we used some of this artificial intelligence, and this was funded by the Aga Khan University, and we have now used some neural networks to look at these signals and differentiate whether this child actually has a silent carditis or not. So you just have to send somebody with this small digital stethoscope in the community, in the school. They'll put it on the chest, and the phone records it, and the phone will send it to the network. The network will send a message back saying that this heart is abnormal. Do something about it. And then you can do further echoes and stuff. This is something interesting, and Dr. Daffer will be interested in listening to this. This is known as the ethiometry or T3 system. So ethiometry or T3 is something that was made in Boston. And then I had some connections, and I used that crying thing that please give me, and so they gave me this whole thing for very cheap money, and so what does this do? This is something that connects into our ICU. So patients who come back from post-operative cardiac ICU, and they are now lying on the bed, everything on their monitor, the blood pressure, saturation, CVP line, everything, it goes into this system. And this system then runs an algorithm, an artificial intelligence algorithm, every 15 minutes. And it gives you this line. Can you see this line above? Green and red? Okay? So when the red line starts hitting 30 and above, there's an indication that your child is going into low cardiac output. And if you leave them like this, in 6 hours the child will have an arrest or a major event. So we have taught our nurses to look at this. You don't have to, we tell them not to do anything, just look at this line. If the line starts getting red, call us. Okay, so they are not calling us for every small thing. And when we intervene, if we give them fluid, we give them inotropes, we control their heart rate, if we are doing the right intervention, the red line will start becoming green. So we will know also standing there, because every 15 minutes the algorithm is running, okay, that are we doing the right thing. And we are developing some really fun stuff with this team now, because we are the only center in low middle income country who was using this. And now we are using protocols. This device is going to tell the physician that your patient is ready for extubation, which is known as the extubation, the readiness of the extubation. So ERA, extubation readiness assessment. So it will do the ERA, and it will send you a prompt that your patient is ready to extubate the patient. So you can do that even. So now you can understand that a time will come that you don't need a very high skilled nurse. You need somebody there who can at least manage something. And you can be sitting in your house with your monitor, and you're looking at stuff, and there's a prompt that comes, and you can intervene based on that. So these are some of the solutions for our part of the world that we'll come up with. I'm going to quickly wrap up. So this is again a decision support system for delivery. So the whole concept is that of task sharing. We share our task with our frontline worker using some of these technology. And if this video plays, this is a very interesting video. If it plays, I hope it plays. Yeah. Now look at this. Oh, it doesn't. The voice is not coming. Anyhow, I'll tell you what it is. So it is a software that was made in India that basically a neonate who's been identified in the community with some kind of a heart disease, far away community, rural hospital for example, and they have to go all the way here to this hospital. As they are traveling, how does the doctor here and the person coming in that car, the sender, the receiver, the transporter, how do these three people communicate with each other? So this is known as the Newport system. So the communication is happening between all of these people, and as you are intervening on the child, the intervention is also being communicated. So the transport of the child is very, very safe in that manner. So this was a good video to, if we had the voice, it would have been a fun one to do and understand. So this is again complex pediatric care. All of these things that I mentioned, that you have to have all of these things in system to actually have a pediatric cardiac care. And then, these are all the different things that I mentioned, that, an empowered nurse is at the very core of the team. Quality consciousness at all levels enables good outcomes at affordable cost. Thoughtful, focus, and targeted collaborations can help facilitate all of the above. So I'm going to skip through some of these slides because these are now, I just want to put this thing up there, and I want you to read this, because we in developing countries at times do not believe in quality care. Poor quality care can lead to other adverse outcomes, including unnecessary health-related suffering, persistent symptoms, loss of function, and a lack of trust and confidence in the health system. Waste of resources and catastrophic expenditures are economic side effects of poor quality health system. As a result of this, only 1/4 of people in LMIC believe that their health system works well. So if people in our countries do doctor shopping, it is our fault, it's not their fault. They just don't trust us because we do not believe in giving quality care. We have to give quality care, and that's the only way we can make them trust. And I have a whole talk on how you develop quality care and stuff, and quality frameworks, and I won't go into that. I'm just going to quickly skip through this. But I have one of our cardiologists, for example, this is one of our cardiologists who I sent to Boston to train in quality improvement sciences. So she's a cardiologist, she's an imager, but she does quality improvement sciences. And so she has developed the whole quality structure for my program. How to pick outcomes, how to work on that, how to do a PDSA cycle and all of those things. And so you have to concertedly kind of look into that and see. She is teaching all of my cath lab technicians. All the cath lab calculations are done by my cath lab nurse. They are better than my fellows at times. They know the calculations inside out. PVR, SVR, QPTQS. You tell them, they just start writing it out. And what it does, because what happens when I'm doing the cath, I can't keep track of everything. So when she looks at a cardiac index of less than 2.5, she'll say, wait a second, doctor, the cardiac index is 2.5. What's going on? So now she's become my eyes. I don't have to do the calculations. She'll do all the calculations and she'll tell me. Literally to the extent that now she'll tell me whether the patient is operable or not. She'll tell me that, the PVR is more than 6 and your AVT was negative, the patient is inoperable. So you can train all of these people and they will get really invested into getting trained, and that engages them. Humans like to grow. Don't treat them like monkeys. If you give them that incentive to grow, they will grow with you and they will stay with you. So again, I'll just quickly skip through this one, quality structure, but this was a very interesting work that we did. This is again a quality improvement work that we did using a key driver diagram. On a 640 slice CT in my hospital on neonate for kids CT scans, we were giving 40 millisieverts. That's a huge radiation. And literally people will say, you need a new machine, you need this. No, we just did business process re-engineering. We re-engineered the way in which we were doing our CT scans. How to order them, how to ask the technician what to do, who's going to read them. And just by doing these simple things, look at how we dropped our radiation. We dropped it down to less than 2 millisieverts. And it is consistently less than 2 millisieverts. So you don't need fancy things. And it's so interesting that when we published this work was cited by one of the radiologists in the US in a TED talk. He gave a talk on a TED talk on YouTube, and he said that we don't need a lot of fancy things. Look at what they did in Pakistan. They solved their problems and stuff. So these are some of the outcomes that I track. I track my outcomes in the cath lab using the C3PO registry, and we published this work also. How do I engage my people? I just published this work in NEGM. It's a very interesting work that I published. And how do you engage your people? And this is a very interesting book I want you guys to read. It's known as Drive by Daniel Pink. And he talks about what makes people do better work. The intrinsic motivators. Extrinsic motivator is easy. Give them more money, give them a better car, they will do work. But they are not the people who will take your system to the next level. Your intrinsic motivator is going to take you to the next level. People who are motivated for growth. They are motivated because of a purpose. My purpose is that the child in Iraq should not get suboptimal care. That is my purpose. If that is your purpose, everything else will come in place. Everything will follow you. The money will follow you. The car will follow you. You just have to learn to have your purpose very clear. And so I use this book quite a bit to engage my employees at my work. And I'm going to leave you guys with this statement. So my purpose, for example, the purpose that drives me in Pakistan, that I came up with this vision statement of mine, that the future of a child should not be determined by imaginary lines on the globe. Just because somebody was born in the US does not mean that they should have a better future than somebody who was born in Basra, Najaf, or Pakistan, or Karachi, or Lahore. Why? It is up to us to solve. How do we make their future better? And it takes a whole village. All the work that I do is not my own thing. I'm somewhere here, enjoying food somewhere. Everybody else is working. I'm just kidding. But they all work. We all work as a team. This is Dr. Kalbe Abbas, who's actually in the ICU now. He's doing all the ICU rounds and everything. And so these are all my machine learning engineers who do all the machine learning with me. These are my surgeons. And for women, this is our women surgeon, a woman surgeon who does, and she's more tough than some of the male people in our programs. And this is all my cath lab stuff. So you have to build your team together so that, these are some of my sonographers, and again my team and nurse practitioners and stuff. And I'm going to end here. I won't go any further. So the summary or the conclusion that I want to kind of give you, and again, as I said, I can easily give you a very physiology talk, heart rate, cardiac output, whatever, that anybody can do. For me, I want to share my journey with you. As in, when I went back, what were the struggles I faced? Because every month I was planning to go back to the US. I don't want to do this, I want to go back to the US. Okay? And that's why I did not take the green card. I said, if I had a green card in my hand, I would go back to the US. So I didn't take a green card. Okay? If I don't have a green card, there's no option, I have to solve it. And I solved it. And in some way, it's still a struggle. Don't get me wrong. It's still a struggle. It's still a journey. There are days in which I have my downs. There are days I have my ups. But there's a lot that I've learned in the process, and I'll be more than happy to share it with all of you guys and how to develop your programs. But let's focus on developing programs, not developing individuals. And I'll end. Thank you. Any questions I can answer, and Dr. Saab can ask me.
Thanks, Dr. Barbaghleh. Thanks for this nice, exacted talk.
Thank you, Dr. Hassan, for this exciting presentation for an interesting subject about the artificial intelligence. And you're telling us about your experience in that field, especially there is a similarity in the conditions between your country and our, both of in Middle East or of in Asia of low resources. And we are hoping to see the initiatives like this to be applied in our country. Actually, we have an ambitious team in the Najaf Center for the Cardiac Surgery and Interventional Catheterization, especially Dr. Dhafar, our colleague. I thank him for his coordination to make this lecture easy and to have you today in our university. They try to do a lot of, I can say it's of a quality procedures in cath and the open heart surgeries to make the new modalities a reality in our society, and they have good privilege for this work. But I'm not sure if we can use or apply like these in the recent future. What do you suggest for us to start for? Yes.
No, absolutely. I think so. Great question. I think on what Dr. Saab was asking me is that is this doable in Iraq? You have to come and see where I also work, and you will understand. And that's why I showed you the village that I applied this. So I think it's all up here. You have to decide. Everything is doable. You just have to think how to work it through. So, for example, if I was, how did I start off? Because I didn't start off here. I started off with just basic stuff. And my first challenge was, how do we even have a multidisciplinary team meeting on a weekly basis? Because the patient was going to the OR, nobody knew who the patient was, I was on call, I didn't even know. The surgeon is calling, I'm not in the OR, I'm somewhere else. So I said, this is not going to work. The echo lab was one machine, because the adult didn't used to give us machine, one room, one machine, and we have a sonographer or a technician who was from the adult side, who used to rotate on 1 month basis. And he or she used to just look at the watch, how can I get out of here as soon as I am done? So I said, this is not going to work. I'm going to just get frustrated, I'm going to just leave everything and go. So I systematically started building the system. How do you build the system? So first we started building, I said first thing we need to do is we need to all sit 1 day per week. We need to sit and discuss all that week's cases in the cath lab or in the surgery. And we started with that. And we started having those conversations and stuff like that, And then people started saying, oh, you know what, I have this complete AV canal, and what should I do with this one? And I said, okay, what you are telling your patient is US data. You are saying, oh, the mortality is going to be less than 1%. But that's from the US, with all those nurses, with all those things and stuff like that. And I said, what is our data? What is our mortality? And they said, oh yeah, let's look into that. So we started so when I started gathering data, I said, okay, how do we put ourselves onto a registry? So I approached Boston, I went to IQIC, International Quality Improvement Collaborative. I put ourselves on that, we put ourselves on another registry, which is the cath lab registry, so that we can track our data. So we tracked our data, we put it on there, and once we started having data come back, we said, oh, fine. They said, for example, I had a problem in our cath lab that for 1 hour, sometimes we just couldn't get access. We are trying to get access, we are not able to get access, the baby is too small. For 1 hour, you are wasting all this time. So we looked at this, we tracked it, we said, how can we solve this problem? We said, okay, we're going to start, all of us are going to learn ultrasound guided access. So we learned ultrasound guided access, and we did ultrasound guided access. So only if you know the problem is when you will try to fix it. Okay? Yes. So by gathering data, so if I was you, I would start developing system in this manner. That, have an organized meeting, have a quality improvement structure. The quality improvement structure, you can start getting data back, just simple data back. Now what to do with the data will be step number 2. And that step number 2 then you can take. But once you have the data, then you can all sit in the room and say, there is a problem here. How can we fix it? And then the solution will come from you. Nobody else can come and tell you the solution. It will come from you. So we have been doing, the reason I got late this morning is because we did ultrasound guided access in the patient.
Yes.
This is the point,
according to challenges
for a new generation.
Yes.
The point is we can't do everything.
Yes.
We can upgrade our system.
Yes.
But should be first from our heart, our brain. Okay. We can talk with everyone, with the minister, prime minister.
Yes.
We went to Al-Atabashiri and talked with them to help us. So we talked with Aga Khan to get
transfer of their experiences.
Yes, to get and share experience. So we can do everything if we want.
So that's why I say you are ambitious team in Najaf Center. And we hope
absolutely.
to.
And that's the reason we are here, is because of Dr. Shafa's effort and Dr. Vada's effort so I didn't go into this, but I actually have this, what is the innovative way of cost sharing?
innovative way of decreasing your cost. And then how do you improve, how do you get private funding? How do you get them to commit? So I'll tell you a patient I did a PDS stent on, and that patient, because of some reason, went to the US. I did a PDS stent, and then they went to the US and they got their operation done, and Netflix have made a movie on it. So Netflix has made a movie that, and so they're like, oh, we did a PDS. So I'm not there for my limelight. I don't care. But how do I use that video now to get funds, to get focus on congenital heart disease in Pakistan? So one of our cricketers, for example, is now doing a lot of advocacy for congenital heart disease. Because in one of the cricket matches, he was playing cricket and stuff, and his friend had a child with heart disease. So he contacted me, and I looked at the child, and then I gave him this talk. I sat them down, everything was okay, and I said, can you tell me, why did Allah put you through this? Why did Allah put you through this, your child having a heart disease? And so they were all thinking, and I said, the reason Allah put you through this, think about it, is that He wants you to help somebody. Because you had the resources of coming to me and getting everything done. There are millions of people in this country who can't have these resources. And he got so excited, he said, oh, I'm going to do this. So that's how you play it. You have to be innovative. At times you have to be that showman, but deep down you know your purpose. The purpose is not that I come on the TV. The purpose is that I get my cause highlighted. So these are all the innovative ways that we have done, different ways of decreasing the cost. How do you improvise in the cath lab and all of this? And Dr. Dafra is already doing this, so I'm not going to go into this. But these are some of the foundations that people have. This is a foundation that was created by a lady who gave me only $20,000 to create this foundation with her. And I convinced her to give me $20,000 for a couple of kids' care and stuff. This is currently close to $20 million fund, this one. Because they put me on the trustee, they gave me the control of how do I make it happen. And I gathered data, I put data everywhere. And every time I went back to the family, I showed them data. And look at what this has done, look at what this has done. I've capacity built, and then there's a whole YouTube video on this also. We made a whole YouTube video and stuff. And they kept on putting money into it. And now this is up to $20 million. And I fund my patients through this and stuff. So all of this is all, again.
Of course they are generous because they're holding the sword of Imam Ali in their logo.
Yes, exactly, they are. This is exactly. So some of the mission that has been funded, our team that has been funded, the tickets and everything has been through them. You're right, absolutely. So we all have to work together, because in the end we all have the same problem. And how do we solve it? And some of these, it's not easy. I'm telling you, Dr. After, there are moments that I'm saying,
yes,
why am I even here? I should go.
It's not easy, but it's not impossible.
Not impossible.
Yes.
Absolutely. That's why I put this one in the end. No? That's why this is all there, but this one.
Yes.
Never give up.
Never give up.
Yeah.
Thank you very much.
Most welcome.
Any question from our students to Dr. Hassan?
Any questions, please come and ask me. Yes, there's a question there.
Doctor, thank you for your questions. So what's your message to us?
Yes, perfect.
As a new generation, because it may be in just a few years they will be in reality in practice and facing these problems, and maybe part of the involved in the artificial intelligence, and here in cardiology and in other fields maybe.
Absolutely,
yes.
absolutely. So the message to you guys is that is never be stagnant. You have to be dynamic. So the process of learning, so this book that I showed you, Drive, read that book. So the three things that drives in the intrinsic motivator is mastery, purpose, and autonomy. Mastery is something that you will never achieve. Irrespective of how much you get better, there will be somebody better than you. And if you understand that, then you will be a constant learner in your life. It was painful for me to open books of mathematics. That's the reason I went into medicine, was not to do mathematics. And I'm now sitting and looking at all these algorithms and complex formulas and stuff like that, because I wanted to challenge myself. I said I'll put something, I have to put myself through a different challenge. I've done enough of this devices and all of this. It's okay, that's also I do, but I need to make myself better.
every case, like why do I scrub in with my surgeon? Why am I in scrubs? Because my surgeon does the case. I go in and I ask him, what was my mistake on the echo? Tell me. Did I do any mistake on the echo? Did I not show you the VSD properly? And then he gives me the feedback. Because I want to get him better. That's mastery. So my message to you is, don't be stagnant. Be dynamic in your life. Anytime you become stagnant, you are gone. You are a dead fish. Gone.
Thank you.
Most welcome.
More question?
Just like Blockbuster is gone. Toys R Us is gone. Amazon took care of every bookstore is closed now. Why? Because Amazon has taken over. They never thought that innovation will come. They thought, oh, we're going to sit and we'll be the kings. But no, it doesn't happen like that. The world will change. No more questions? Come on, guys. One more. No.